Good afternoon to all of you for the second day of the PROSA webinars. Those who were with us yesterday know already that this is a joint initiative with three organizations, the PROSA Conference Organization, PACT from Switzerland, and Pediadol from France. We'll explain that in a minute a little bit further. Welcome to this webinar, which will take from 5 o'clock to 7 o'clock, at least Maastricht time, Central European time. Welcome to all of you with a different program compared to yesterday. This is us, the three of us who actually worked together to collaborate on this conference, on this meeting. And I'm very happy to give the floor shortly to Bénédicte Lombard from Pediadol. Bénédicte, can you shortly introduce yourself and who you represent? Are you there, Bénédicte?
Oui, bonjour.
Okay. Can we see you, Bénédicte? Your
Oui.
screen is on? Yeah, okay, wonderful. Okay.
Oui.
Can you shortly tell something about Pediadol?
Oui, bien sûr. Bonjour. Donc, j'organise avec PROSA et PAX ce webinaire au nom de Pediadol, qui est une association qui diffuse de la connaissance autour de la douleur de l'enfant en France. Cette association existe depuis plus de 30 ans et a un site internet et organise un congrès chaque année qui réunit de très nombreux professionnels. Son fondateur est Daniel Hannequin. On lui doit l'apparition du Méopa, par exemple.
Okay, thank you. Cyril, my co-chair for today, please.
Hello, Pete. Hello, everyone. So my name is Cyril Sayoun. I'm a pediatric emergency medicine physician in Geneva, in Switzerland. And I am lucky to represent our organization, PAX, the Pediatric Association for Comfort and Trust Switzerland, which is 1 year old yesterday, which really got inspired by the work of Pediadol, by the work of PROSA, and aims to promote pediatric care while respecting the child's right to be protected from avoidable pain and avoidable stress, with objectives throughout training, sensibilization, and further. We had our first Congress in June of last year in Geneva, which was very well received, and we have other plans for the future, which we'll talk about later on.
Okay, thank you, Cyril. So this is us. We decided a few months ago to organize this common webinar for free. We found funding in our organizations, and we found it extremely important to create this first European initiative. And actually, this is all because we share a common vision. And our common vision is that we want to advocate and promote a new way of pediatric caring that prioritizes the children's dignity and their right to be protected from procedural pain, fear, distress, or forceful restraint. And we want to do this by considering the children's physical, emotional, and psychological well-being during medical procedures of central importance in all procedural decisions. So not only the goal of the procedure itself, the healing goal, whatever, the diagnostic goal, considering the comfort, the well-being as of central importance. And this means that we want to adopt a philosophy towards a warm, welcoming, safe, and reassuring childcare defined by the child's individual needs. So what we are talking about is not only about techniques for sedation and analgesia, we are talking about a deeper philosophy supporting a new vision towards pediatric healthcare. And by doing this, we want to move medical procedures and actually medical care in total from fearful events to trustful experiences by the implementation of multimodal evidence-based strategies for procedural comfort that come as a standard of care in all settings where children have medical procedures. So not only in the hospital, not only on the intensive care unit or the high care unit, not only on the operation room, but also the outpatient clinic, also the places where children, for example, get their vaccinations. And what do we want to do? We want to enhance and widely diffuse competency in procedural comfort. And that's what we consider as our most important contribution to healthcare, to educate professionals, caregivers, children in all aspects of pain, and fear-free medical care. So not only professionals, but also parents, also children, helping to become competent in comfort care. And we want to establish interprofessional, interdisciplinary collaboration because no one of us can do this on his own. We need each other. We need different disciplines, different professions to make this possible, to make this a new reality. And what we as organizations want to do is creating a European network for research, education, and awareness. And if any of you is involved in his own local, national society, whatever, please inform us, join us. We are happy to welcome you and to work together in the future. Yesterday, we had a very nice program, which was more on the so-called non-pharmacological approach, especially Gabriel and Benedict talked about the words for trust and what you could do more than words only. And then Cyril introduced the first concept of anxiolysis and minimal sedation. Today, we have a different program. First, Lucy Bray will speak about the recently published rights-based standards for children having procedures. Then Julia Höffe from, there's written Basel, it's not Basel, it's Chur in Switzerland, about advanced nitrous oxide sedation. And then Koen from Leuven will talk about his experience with nurse-led intranasal dexmedetomidine sedation. And Cyril will immediately take over the floor and will introduce these speakers and will guide us through this program. Some practical things. First of all, you have heard that Benedict was speaking French. The rest of the speakers, I assume, will speak English today. But there is instant translation. When you go to the bottom of the Zoom environment, you will find this globe, the symbol, the globe symbol. There you can choose English, French, or German, depending on the country you're living in. And we heard yesterday that the quality of these translations are very good. So please switch them on so that you can follow in the language you prefer. Each lecture will take about 25 minutes. Use the chat environment to ask questions or to comment during the lectures or after the lectures. We will follow the chat environment and we will select questions from that environment to ask the speakers afterwards. The last 30 minutes of this meeting will be used for discussion based on your input. And finally, when you have followed these meetings, you will receive a certificate of participation. And the lectures will be recorded and will be made available afterwards on our website, but you will all receive email information about this afterwards. So now I'm going to close this part of my story. Yeah, that's done. And I'm very happy to give the floor now to Cyril to introduce the speakers and to guide us through the rest of this fascinating program this afternoon. Cyril, it's all yours.
Thank you very much, Pete. Thank you for all the speakers. It's my honor to be introducing you today. Perhaps while Lucy shares her screen, I will quickly introduce her. So Lucy is a children's nurse, as she likes to say, and a researcher who works as a professor of child health literacy at Edge Hill University in the UK. And she's going to be talking to us about iSupport. I look forward to hearing her talk. I haven't heard it before. So Lucy, the floor is yours.
Thank you. Oh, thank you. I feel very honoured to be here this evening alongside such esteemed colleagues. So I'm hoping that I will remember to speak slowly to help the translation, but please do shout out and have a habit of talking very quickly. So I'll try and just slow down. So I'm here this evening to talk about the iSupport standards for children having tests, treatments, and examinations and interventions. I'm going to briefly just touch upon key points in a child's procedure. The lectures yesterday really covered some amazing topics, and I just want to outline some key points along that procedure and then talk about the iSupport standards. I really just want to acknowledge that even very, very simple healthcare procedures are often conducted within quite complex systems with lots of agendas. So we often have the child's interests, parents' interests, healthcare professionals' interests, and the organisational interests. So even simple procedures are complex interactions. I also want to just recognise right at the beginning that every child is an individual with different needs, competencies, abilities, preferences, and experiences. And these will change from when a child is in their normal day-to-day life compared to when we bring them into a very strange environment. They will not be the children that they are when they are not in hospitals. And we just need to be mindful of that. So I think it's important just to start to acknowledge that lots and lots of children have positive procedural experiences. Certainly there were some amazing examples of really great practice talked about yesterday in the presentations, but unfortunately many children do not. Pete talked about how we're not just focusing on surgery, we're not focusing on necessarily invasive procedures like blood tests, cannulations, because even very minor day-to-day procedures are not always minor for a child. So administration of Calpol, removing a dressing, removing a plaster, taking a blood pressure can be quite anxious, can make children quite anxious when they don't know what's happening and they do not trust the people that are next to them. So we need to be very mindful that even minor procedures are really important interactions between us as health professionals and children to build trust. I always think it's really important to acknowledge that what we do within healthcare does cause children harm, and when it goes wrong can cause children trauma. We're increasingly gaining an insight into the fact that children do remember. For many years, we've talked about children being too young to remember, too young to understand. This is not the case. Even very small children can remember very poorly managed procedures from when they were small. And we know that this has lifelong lasting effects. And we know that trust is very easily lost with children and young people and very, very hard to restore. And every interaction that we have with children and young people is really important. So this is a little bit of a busy slide. Tried to put everything in one place. Just thinking about the journey that a child takes through, if we think about a hospital experience, we've got lots of evidence to show that when children are prepared and informed, they're likely to have better healthcare procedures. Obviously, what that looks like will depend on the preferences for communication and the abilities of those children and young people. But we know that sometimes children are still left not knowing what's going to happen. We know sometimes parents are left not knowing what's going to happen. And so we have children arriving at the healthcare service being unprepared and unsure and anxious. So these children and these parents can arrive in hospitals and clinics which are noisy, smelly, unfamiliar, scary places, particularly for children and young people who are autistic. This can be very, very stressful, very unfamiliar, and result in sensory overload for these children and young people. And so already we might have a child that's unprepared. We might have a child that's dysregulated because of the environments in which we're bringing these children and young people. So the initial interaction that these children have with health professionals is so important. How we communicate, how we validate those children's emotions. And so we know if children are anxious and stressed, they're less likely to be able to engage in a verbal conversation. They're less likely to be able to verbalize their rights and their feelings. And so these communication that we're having with children and young people is absolutely essential in what can be a very small window of opportunity to get to know those children and young people. Sometimes in outpatients, it can be 1 minute taking a child down a corridor to a clinic room. And within that minute, we have to try and connect with that child, see that child, understand how that child might be feeling. We know we continue to talk over children and talk at children, despite the evidence that tells us that that isn't the best approach. So during a procedure, we know that children and young people will benefit if they can have choices. And we talked about that yesterday, that children and young people can be given choices, even small choices can make a big difference to making a child feel less overwhelmed, less out of control during their procedure. We know that if we can just stop before a procedure and make sure that that child and young person's parent is calm and ready to support their child, to make sure they know what's expected of them, to make sure that that child has had some choices, has got appropriate distraction that they have been able to choose that engages them, not the same distraction method for every child that enters that room, but that they've had an ability to choose the distraction that works for them. They've had appropriate analgesia and the analgesia has had time to work. And we've just stopped and thought about a plan A for this child's procedure, but also we've openly acknowledged what a plan B might be. And later I'll argue about the fact that if we don't talk openly at the beginning about under what circumstances we might stop, we know that that makes it really unlikely that we will stop. So if we have a child who is stressed and anxious and becomes distressed, We know from the research that we've done that these children are likely to be held against their will for a procedure to be completed in many cases. And these are not urgent or critically important procedures, but these can be non-urgent procedures. And we know children with learning disabilities or autistic children, young people are, again, particularly likely to be held because we see their behaviour as challenging behaviour rather than distress behaviour because of the situation that these children and young people are in. And so often when we respond, we will hold. And so we justify this by explaining that it's in a child's best interests to get a procedure done really, really quickly. Evidence doesn't support that. We will explain behaviours by saying that the child is young and so is unlikely to be able to sit still or understand. We don't have evidence to support that. And we have evidence that shows from some of Benedict's wonderful work that when we get in the thick of a procedure, when we are concentrating on the task, it's very easy to lose sight of the child. We lose sight of when a supportive hug from a mum becomes a hug and an arm from a professional, a hug and an arm and a leg from two professionals. And suddenly we're holding a child with 3 adults for a non-urgent procedure. And we need to be really aware of the impact of that. Often when children are coming for procedures, we see them once. We don't always see the impact of our actions on the next time the child steps through a different healthcare service with a different health professional. The impact of our actions, not just in the short term where we might have a distressed child, but the impact of those actions on a child or young person in the long term as that child then has to engage with healthcare services and healthcare professionals in the future. So when a procedure has gone badly, what happens after the procedure? And it was interesting yesterday to think about the fact that I would argue that there's a bit of an empty space after a procedure's happened and a child has been held or restrained against their will. Everyone is very happy to leave the room as quickly as possible and get the child comforted back in bed. And I would argue that we're not very good at documenting what happened. We're not very good at supporting the child and the young person to make sense of what has happened in that situation. And I would argue that a parent is left often feeling that they've betrayed their child, have not advocated well for their child, and health professionals recognise that things did not go well but move on to the next task. So what do we have within healthcare? Do we have a culture of acceptance? Well, I would argue that no health professional enters into a procedure to purposefully restrain or cause a child distress, but it happens and it happens frequently. And I would argue that we don't necessarily think about the use of restraint or a child experiencing distress as an error, as we would think about other medical errors or other errors within practice. Do we recognise that an error? Do we note it as a poor outcome if the cannula has been taken, if we've got a good film picture, if we've got what we needed and the child is distressed? Do we note that as an error or a poor outcome? We know there's never going to be enough money or resources, but I think certainly some of the presentations yesterday and some of the evidence that we have shows that it takes very small little changes to actually make a huge difference to a child's healthcare experience. And also we need to think about the fact that, yes, it might be quicker this time, but this child is going to take much more money, much more resources, much more input next time because they have been harmed and traumatized. So the argument about things taking a little bit longer is a poor one, I would argue. We know that evidence takes quite a long time to get into practice. And we know that this isn't because people are lazy or unwilling or don't understand, but it's often that knowledge and all of that evidence that we have has not been translated into a simple and usable form. And certainly this is where iSupport aimed to address. So I'm just going to very quickly provide an overview of our rights-based standards. And I present this on behalf of an amazing team of colleagues, some of which are present today. And it really has been a highlight of my career. So my work focuses on procedural holding and restraint. And I would argue that I can quote research from 15 years ago, 20 years ago, that would still absolutely have relevance today. I don't believe we're doing anything that different in the last 20 years. I feel quite proud that we've conducted lots of research and we've made lots of animations and comics for children and young people. I feel very proud to have conducted that work. But it was a visit from this young person, Katie Dixon, in 2019, who came to my office as a young person who'd had multiple episodes and experiences of restraint for non-urgent procedures throughout her childhood. Katie suffers with PTSD and cannot access adult health services because of that, despite intensive psychological investment. And Katie really said that she was pleased to see the work we were doing, and the children no longer get held in practice. And really, that was the departure point for iSupport, in the fact that nothing has changed since Katie was a child, and we continue to conduct these procedures and leave children and young people with trauma. And so we started our 2-year multi-phase, multi-stakeholder development project. This is the people that shared their photos. This is some of the amazing team of iSupport. So we are an international team based across all four continents, however many continents there are. There are 50 experts of us, including doctors, clinical psychologists, most importantly, young people and children and parents. We have youth workers, we have place specialists, we have academics and also child's rights experts. And we started off, really, our departure point was to try and define clinical holding and restraint, to get a sense of, I believe if people had a better grasp of the difference between a supportive hold and restraint, then at least we would be clear about what we're doing in practice. But I think definitions are often blurry and people are quite uncertain about what practice looks like. And so our departure point was to clearly define that. And we started, that was where we started with our initial meetings. We then conducted some consultation with young people and with parents, and it became obvious that we needed to broaden our focus. So the young people were saying it was really important, of course, to get supportive holding and restraint clearly defined, but actually it was the information, it was the choices, it was their support around the whole procedure that made holding less likely to happen and also made the procedure a positive experience. And it was incredibly powerful to listen to many of the parents that we spoke to who could acutely remember their own procedural experiences 20 years ago, where they could remember the wallpaper on the wall behind the dentist where they had been held against their will. And so these are long-term trauma experiences that we are sometimes causing these children and young people. So we conducted an online survey as part of phase 2, where we kind of tried to map out what these standards could look like. And we went to further groups of children and young people and parents. We really carefully paid attention to reach out to groups of children and young people who may be less heard when we're developing healthcare services and standards. So we spent time with youth groups of young people with learning disabilities, certainly autistic children and young people, to make sure that the standards worked for all children and young people. After that stage 2, we then had to change the focus again slightly, and we started to gain a sense of this consensus that was building. It was a very messy, a very difficult and challenging project over those 2 years to try and reach consensus that worked across all children and young people and all the settings that we were engaging with. But we learned so much along the way. So we also used creative methods to make sure that children who necessarily wouldn't be able to share their views in traditional means could share their views and help us develop both the content and the imagery of the standards. So what are they? So the standards are for all children and young people aged 0 to 18 years. And this really talks to the fact that children don't suddenly gain competence and rights at age 5 or 7 or 11. Children have rights from when they are born. And judging children and young people by their ages can be slightly dangerous. It means we make assumptions about their abilities, assumptions about their skills. And so the standards apply for all children and young people, having all tests, treatments, examinations and interventions. So this covers a very minor administration of oral medicine to a child having surgery. And the standards speak to the fact that it's important to look after the short and long term. So what impact in the long term do our actions have of the physical, emotional and psychological well-being of children and young people, and how they should be of central importance. And the approach is really grounded in the fact that we are looking to minimise anxiety, distress and harm. The standards explicitly challenge the use of restraining holds for clinical procedures, whether intended or labelled as such. So if we're doing restraint, let's not call it clinical holding, it's restraint. And we shouldn't be using restraint unless the procedure is life-saving or emergency, or the child is going to experience significant harm. We should be brave enough to openly acknowledge what practice we are using, and I believe that will be the start to making a change in practice. We believe we have the first international consensus on definitions of supporting and restraining holds. The standards are broad principles of practice based across 6 areas, really underpinning a child's procedural experiences. It is a 4-page, freely available PDF with clear statements written under each of the main areas. As we began to speak with children, young people and families, it became obvious that they were keen for a version for themselves. And if we think about the complex interactions that happen, if we have a shared expectation when everyone arrives at that procedure of what good procedural practice looks like, then hopefully that is more likely to happen. So we have the version for professionals, we have the version for families. The young people were quite concerned that they may have a standard for what good procedural practice would look like, but how could they enact that? How could they become empowered to make some changes themselves? And so we developed the prep sheet with some children and young people, which just provides a professional with a snapshot of, these are things that I will talk about, these are things that I'm interested in, this is what will engage me, these are things that have worked for me before, these are things that don't help me, these are things that I'm worried about. We then developed some case studies just to demonstrate the small tweaks in practice that can happen to actually make a big difference to children. We've tried to spread these case studies across ages, any diagnosis, and a range of procedures. And then, of course, everything is underpinned by evidence. We are in the final phases of developing a comic strip for younger children and young people to enable the messages about their rights in healthcare to reach as many children and young people as possible. I'm not going to read these out, but these are the 6 statements that underpin the standards for professionals. So a child has rights to be cared for by professionals who have the appropriate knowledge and skills to support their physical, emotional, and psychological well-being and rights before, during, and after. So not just someone who's very good at cannulation, but someone who can think about that holistic care of a child. A child has rights to be communicated with in a way which supports them to express, whether that be verbally or behaviourally, by crying, by being withdrawn, by being and looking scared. We need to listen to the way that these children are communicating their views and feelings, and we need to take those seriously and act upon them. A child has rights to be provided with meaningful, individualised and easy to understand information and help them prepare and develop skills to help them cope for their procedure. A child has rights to be supported to make procedural choices and decisions, and for these choices to be acted upon to help them gain some control over their procedure. So we're assuming that a child can be involved rather than assuming that they may be too young to be involved. Oh, well, I'm not sure what happened there. 1 second. Let me sit back. And yeah, the child has rights for their short and long-term best interest and well-being to be a priority in all procedural decisions. So not the parents' priorities to get out of the clinic, to get back to work, not the professionals' interest, not the institution's interest, but the child's interest first and foremost. And a child has rights to be positioned for a procedure in a supportive hold if needed and should not be held against their will. And we define a supportive hold as one where a child feels calm, secure and settled and agrees to the procedure and positioning and does not express signs of refusal. If it's not that, it's a restraining hold, which is any hold to prevent a child moving freely against their choice or will whilst expressing signs of refusal. And again, we should be brave enough to acknowledge what we're doing. If we feel that that was the right decision, it was the right decision, and we should feel confident to be able to document that and acknowledge it. We're very fortunate to work with amazing professionals who've managed to translate our standards into multiple languages. We don't have them in French yet, Benedict. And because we're really, really keen to actually change practice, we've worked quite hard to develop an audit based on the standards that can gain the views of children, parents and professionals on their procedural experience. And these, at the moment, we are implementing them in various departments and hospitals where we will measure practice and get a sense of what practice looks like against our standards. And then we can really target interventions and changes to help departments see, for these children and young people's pathway through this department, what can we do to try and improve our care and improve how we are, the procedural experiences of children and young people. And I think when we think about the complexity of these procedures, even simple procedures, we're really keen, we're trying to target all the levels. So we're working with children and young people, we're running workshops and education days with children and young people to try and equip them with knowledge about their rights. We're working with parents so they can understand what their roles are. Do they know what they should be doing? Where did they find information to prepare their child? We're working with professionals to try and challenge some of the assumptions and learned practices within care. But that's all really hard unless we challenge at an organisational level. So working with key organisations, trying to raise the profile of, yes, talking about restraint and forceful holding is uncomfortable, but as soon as we don't talk about it, it's likely to persist. So let's have those brave conversations. Thank you very much. I think I'm within time. Thank you.
Yes, you are. Thank you so much, Lucy. I think there's going to be plenty of questions which we're going to leave to the end, but thank you for opening our eyes and continuing on this wave of philosophy behind what we do. We saw Benedict yesterday, we see you today, and we're really lucky to be able to share this with everybody here. So our next speaker, and we will reserve questions for Lucy, for Julia, and for Koen for the very end, but our next speaker is Julia Schaffer. So I asked Julia how she likes to be introduced, and Julia is a pediatric emergency physician since 2010. So she's got 13 good years as an emergency physician for children. She spent some years in Montreal, and this interest in patient-centered analog sedation has been there for more than 10 years. And I wouldn't be able to complete Julia's presentation without saying that first, she's a mountain lover, but second, she's our vice president at PACTS. So while Julia prepares to share her screen, allow me to thank her again for participating. She will be talking about nitrous oxide plus. We yesterday talked about nitrous oxide a little bit, and today she'll be adding to that. The thought was, what is a little bit of the low-hanging fruits? What is it that a lot of us can do in our specialties? Yesterday was some, and today is more. So the floor is yours, Julia.
Herzlichen Dank, Cyril. Es freut mich sehr, in diesem Rahmen über Lachgas sprechen zu dürfen. Und ich nehme das gerade auf. Es geht ein bisschen um die Low-Hanging Fruits und die Frage, wenn man mehrere von diesen Fruits zusammennimmt, gibt es einen Fruchtsalat oder gibt es irgendetwas Vernünftiges? Und als erstes muss ich finden, wie ich meine Präsentation weiterbringe. Moment. Ja. Meine Literatur stammt vor allem aus PubMed und das fängt schon damit an, dass Pete vorher erwähnt hat, dass wir gerne evidenzbasierte Medizin hier praktizieren und weiterverbreiten wollen. Die Literatur und die Studienlage ist aber ziemlich spärlich, vor allem für Lachgaskombinationen. Es ist alles sehr, sehr anekdotisch und ich möchte das ein wenig zusammentragen. Ehrlich gesagt ist Lachgas selber schon großartig. Warum würde ich also überhaupt auf die Idee kommen, dazu etwas dazunehmen zu wollen? Und wenn man das schon will, gibt es natürlich ganz viele verschiedene Cocktails, die wir verwenden könnten. Und ich beschränke mich auf 3. Lachgas plus Midazolam, auch ein Low-Hanging Fruit vielleicht. Lachgas plus Dexmedetomidin, etwas, was wir sicher sehr, sehr gerne zusätzlich einführen. Und dann Lachgas und Fentanyl, wo ich ein bisschen eine persönliche Beziehung dazu habe. Aber erst ein kurzer Schritt zurück. Wenn ich darüber rede, wie es um eine Analgosedation steht, dann gibt es sicher ganz unterschiedliche Meinungen dazu. Und vielleicht muss man sich an dieser Stelle immer fragen, was ist im Vordergrund oder was ist das, was wir eigentlich wollen? Und eigentlich wollen wir ein bisschen alles. Wir wollen erstens, dass die Kinder total entspannt sind, wenn wir unsere Sedation durchführen. Wir wollen, dass sie etwas haben, dass sie keine Schmerzen haben, wenn wir dann tatsächlich etwas Schmerzhaftes machen müssen. Am liebsten hätten wir etwas ohne Nebenwirkungen, was eigentlich völlig unkompliziert stattfindet, wir also eigentlich nicht besonders viel Erfahrung haben müssen und was ganz schnell wirkt und ganz schnell wieder aufhört zu wirken, weil Lucy hat zwar gesagt, es geht wirklich um das Interesse des Kindes, aber es ist natürlich trotzdem so, dass wir eine gewisse Rahmenbedingungen haben, die wir nicht ganz ausschalten können. Warum also Lachgas? Weil Lachgas eigentlich das ist, was wir im Deutschen eine eierlegende Wollmilchsau nennen, nämlich etwas, was alles kann. Es ist gegen Schmerzen, es entspannt, es hat wenig Nebenwirkungen und es hört schnell wieder auf und es hat auch schnell angefangen zu wirken. Und es hat den großen Vorteil, wir brauchen keinen Venenzugang dafür. Und das ist sicher ein wichtiger Punkt, warum man dann Lachgas auch mit anderen Medikamenten kombiniert, obwohl es vielleicht je nachdem durchaus auch andere Optionen gäbe. Aber die Kinder müssen die Maske akzeptieren können. Und das ist ein bisschen kooperationsabhängig, altersabhängig, nicht ganz so einfach. Und ich klammere ein bisschen das aus, was aber eigentlich mit am wichtigsten ist. Wenn ich einen Weg finde, diese Maske zu verkaufen, wie das Cyril gestern eben erzählt hat, dann habe ich eigentlich am besten gewonnen. Also wenn ich mein Medikament mit anderen Medikamenten ergänzen muss, damit überhaupt die Maske akzeptiert werden kann, ist das schon so ein bisschen eine fragwürdige Situation. Aber manchmal ist das einfach nötig oder man kann sich fragen, ob das wirklich eine gute Option ist. Lachgas 50 ist sicher etwas, was vor allem gegen Angst wirkt und relativ wenig gegen Schmerzen. Wir haben natürlich auch Lachgas 70-prozentig, was durchaus auch gegen Angst, aber durchaus mehr gegen Schmerzen ist aber dann nicht mehr eigentlich eine low-hanging fruit. Es ist nämlich nicht mehr eine minimale Sedation. Und wir müssen uns sicher klar sein, dass das Nebenwirkungsprofil sicher ein ganz anderes ist. Ich komme noch einmal kurz darauf zurück, warum sollte ich einen Cocktail nehmen, wenn ich eigentlich ein ganz feines eigenes Medikament habe? Und das meistens, weil ich bestimmte Eigenschaften der entsprechenden Sedation oder Analgesie verstärken möchte. Am besten ohne Venenzugang und am besten mit den besten Effekten von den Medikamenten, ohne dass es mehr Nebenwirkungen gibt. Das könnte man ein bisschen in Frage stellen. Und es ist sicher so, dass es zwar mehr als 20 Jahre her ist, dass dieser Artikel publiziert wurde, aber auch heutzutage gibt es sehr wenige Studien, die zeigen, dass eine Kombination von Medikamenten hilfreicher ist, was die Patientenversorgung, was den Komfort, was die Sicherheit und alles andere, auch einschließlich der Kosten, angeht und es nicht sinnvoller ist, sich zu überlegen, was ist denn das, was ich wirklich möchte an dieser Stelle. Und das ist, was ich mir wirklich wünsche, ist, dass ich mir vorher überlege, was mein Ziel ist. Brauche ich vor allem etwas gegen Schmerzen? Brauche ich vor allem etwas, das mir eine Prozedur überhaupt ermöglicht, weil das Kind selber nicht ruhig halten kann und es gar nicht schmerzhaft ist oder wenig schmerzhaft ist? Oder geht es mir um beides? Und je nachdem ist es wirklich sinnvoller, sich vorher zu überlegen, was mein Ziel ist und nicht einfach eine Mischung von verschiedenen Sachen dann zusammenzubringen, sondern sich zu entscheiden, was im Vordergrund steht. Fangen wir an. Wenn ich also Lachgas mit Midazolam mische, dann erwarte ich eigentlich mehr Sedation, also mehr Entspanntheit und dann je nachdem eben auch damit, dass es relativ kurzwirksam ist, aber nicht, dass es gegen Schmerzen ist. Wenn man in die Literatur reingeht und sich fragt, warum man das tun sollte, dann gibt es insbesondere einen Artikel von Luhmann vor über 20 Jahren, wo ein Vergleich stattgefunden hat von Midazolam, Lachgas und einer Kombination davon mit dem Ziel, Wundversorgung bei Kindern im Notfall zu machen. Und interessanterweise war im Studiendesign nicht einmal vermerkt, warum die Kombination jetzt das Ziel sein sollte, sondern es ging um die einzelnen Medikamente. Und schlussendlich muss man auch sagen, dass das Ergebnis nicht besonders vielversprechend war. Die Interaktion hat nicht mehr geholfen als die einzelnen Medikamente, mit dem einzigen Unterschied, dass das Kombination Lachgas plus Midazolam ungefähr ähnliche Nebenwirkungen hatte wie Midazolam alleine. Und Ich bin wahrscheinlich nicht die Einzige in dieser Gruppe, die eher etwas skeptisch bei Midazolam ist und sich sicher eher für Lachgas als für Midazolam generell entscheiden würde, wenn es die Möglichkeit gibt. Wer viel mehr damit arbeitet, sind die Zahnärzte. Und ich hoffe natürlich, dass solche in dem Publikum sind und sich auch an der Diskussion nachher beteiligen können. Und da ist der Weg ein bisschen der andere. Häufig wurde früher Midazolam primär gegeben und dann kam Lachgas mit dazu. Und man hatte ein bisschen die Hoffnung, dass man damit etwas weniger Midazolam geben könnte und die Kooperation der Patienten verbessern. Gleichzeitig gibt es einzelne Studien, die genau das Ziel hatten, nämlich dass man Lachgas geben wollte, die Kinder aber die Maske nicht toleriert haben und man die Idee hatte, dass wenn man Midazolam dazu gibt, dass die Maske dann besser akzeptiert werden kann. Kann man ein bisschen in Frage stellen, weil insbesondere Midazolam nasal, wie wir alle wissen, ist auch nicht angenehm und wenn ich das Kind dann festhalte, was wir ja sowieso nicht machen wollen, um einen Nasenspray zu geben, der brennt, damit sie danach zu verschlafen oder sediert sind, um sich gegen die Maske zu wehren. Ihr merkt schon, ich bin da etwas skeptisch. Und entsprechend ist es auch so, dass wenn man sich die Studien anschaut, als eine Art Systematic Review, der insgesamt 4 Studien mit eingeschlossen hat, dass eigentlich keine signifikante Verbesserung der Kooperation dargestellt worden konnte, wenn man Midazolam mit Lachgas kombiniert. Allerdings, wenn man das jetzt zusammenfasst, ernsthaft, geht es, wenn dann, darum, die Maske akzeptieren zu können, nicht eine gesamthaft bessere Sedation im weiteren Verlauf zu haben. Über Nebenwirkungen gibt es zu wenig Informationen. Gehen wir zum nächsten Medikament, Dexmedetomidin plus Lachgas. Ist das eine gute Idee? In der Theorie sicher, weil eigentlich Lachgas einen gewissen analgetischen Effekt hat. Dexmedetomidin in der Theorie zumindest auch, zumindest in Kombination, in der Praxis durchaus auch bekannt. Was vielleicht noch wesentlich ist und in dem Zusammenhang man sich auch gut überlegen muss, ist, die Sedation wird mit Dexmedetomidin deutlich verlängert im Vergleich zu Lachgas, weil der Wirkeintritt später ist und auch die Wirkdauer deutlich länger ist. Das kann durchaus das Ziel sein. Studien gibt es hier auch mit Ratten. Und diese eine Studie fand ich insbesondere in der Theorie sehr, sehr spannend, weil sie gezeigt hat, dass wenn man Lachgas lange genug gibt und dann mit Dexmedetomidin mischt, dass dann der analgetische Effekt gesteigert wird, und zwar additiv gesteigert wird und auch deutlich länger anhält, als wenn man Lachgas alleine gibt. Und die Idee dahinter ist, dass verschiedene Subtypen der adrenergen Rezeptoren dort involviert sind, auch der noradrenergen Neurone mit involviert sind, auf der Höhe des Rückenmarks am ehesten, und dass der Effekt von Lachgas ein begrenzter ist, der mit Dexmedetomidin dann verlängert werden kann. Ob das für uns klinisch relevant ist, ist so ein bisschen fragwürdig. Es gibt kaum jemanden, der oder die Lachgas für eine längere Zeit, sicher nicht länger wie 30, 40 Minuten verwenden würde, sodass dieser Effekt in der Klinik vermutlich nicht wahnsinnig relevant ist. Wenn wir aber 2 mindestens mild bis moderat analgetisch wirksame Medikamente haben, wäre das möglicherweise etwas, was durchaus einen Effekt haben könnte. Auch hier wieder die Zahnärzte haben Midazolam mit Lachgas und Dex mit Lachgas verglichen und damit genau das gezeigt, was man erwarten kann, dass die Sedation verlängert wird. Die Effektivität sei in etwa gleich gewesen. Allerdings ist das eine retrospektive Studie, wo insbesondere schwerwiegendere Eingriffe in der Kombination von Dex mit Lachgas gemacht wurden und man den Eindruck hatte, dass das hilfreich ist im Vergleich mit anderen Eingriffen. Warum ich das machen würde, wenn sowieso alle Regime ungefähr ein ähnliches Outcome haben, hat vermutlich mehr damit zu tun, dass unsere Maßnahmen oder unsere Scoring-Systeme, unsere Untersuchungen, wie eine effiziente Analgosedation aussieht, nach wie vor sehr unklar und nach wie vor viel zu wenig standardisiert in Studien geprüft werden. Und das ist sicher ein Punkt, der uns in der Zukunft weiter beschäftigen wird. Und wir kommen dann zu dem Punkt, der vorher wieder Thema war, nämlich die Maskentoleranz. Und da hat Cyril insbesondere vor kurzem eine schöne Studie publiziert über DEX als Möglichkeit, um insbesondere bei Kindern mit Autismus-Spektrum-Störung oder mit Entwicklungsverzögerung, die nicht in der Lage waren, die Maske an und für sich zu tolerieren, bei denen aber Lachgas notwendig schien für mild schmerzhaft wirkende Prozeduren wie Impfungen oder Blutentnahmen, dass eine Kombination tatsächlich die Behandlung deutlich erleichtert hat und die Zusammenarbeit mit der Familie. Und das ist sicher ein wesentlicher Punkt, eine familienzentrierte Analgosedation in diesem Zusammenhang tatsächlich von Vorteil war. Das heißt, in diesem Fall, ehrlich, viel additiver analgetischer Effekt ist in der Praxis vermutlich nicht der Fall. Sedation ist sicher verlängert, wenn ich beide Medikamente nehme. Das muss ich mit einschließen. Und insbesondere bei Kindern, bei denen Verhaltensauffälligkeiten oder Autismus-Spektrum-Erkrankungen bekannt sind, ist es sicher eine hilfreiche Kombination, um überhaupt erstmal wieder Vertrauen schaffen zu können für eine Interaktion zwischen Ärzten, Pflege und Patienten. Und dann komme ich zu der Kombination mit Fentanyl. Da geht es weniger um die Sedation, sondern auch um die Kombination damit, Schmerzen zu behandeln und im Vergleich zu anderen Medikamenten trotzdem eine relevante Zeitersparnis zu haben. Und hier muss man sicher sagen, dass es etwas mehr Studien gibt, insbesondere aus der Notfallmedizin. Für kurze Prozeduren mit nicht sehr starken Schmerzen gab es durchaus positive Effekte. Das heißt also bei kleinen Verbrennungen oder bei Frakturrepositionen ohne große Manipulationen ist das sicher eine Kombination, die gut funktioniert. Allerdings vor allem in der Kombination mit Lachgas 50, nicht so sehr mit einem höherprozentigen Lachgas, wie in dieser größeren Studie aus Zürich, wo das Zusetzen von Fentanyl zu Lachgas 70/30 keine wesentliche Verbesserung, was Schmerzen oder Sedationsscore angeht, gebracht hat. Das gehört immer mit dazu. Wenn wir Fentanyl und Lachgas kombinieren, dann ist es gut wie immer, dass man seine Medikamente gut kennt und es hilft, einen Abstand einzuhalten zwischen Fentanyl und Lachgas, insbesondere wenn man das intranasal gibt, weil das später angeflutet wird und wir den maximalen Effekt, aber nicht den maximalen Nebenwirkungseffekt haben wollen zum Zeitpunkt der Prozedur. Es ist sicher wichtig zu wissen, dass die Sedationstiefe erhöht wird durch eine Kombination von Opioiden mit Lachgas und dass es mehr Nebenwirkungen hat, wie generell zu erwarten, wenn wir mehrere Medikamente kombinieren. Im Vergleich allerdings mit Ketamin und Midazolam, was sicher eine der Hauptalternativen ist, die wir auf dem Notfall nutzen, hat das EHA ein besseres Nebenwirkungsprofil gezeigt in dieser Studie aus Spanien und gleichzeitig eben eine durchaus positive Korrelation der Zufriedenheit von allen Familien und Medizinern. Die Effizienz war vergleichbar. Es gab aber deutlich weniger Nebenwirkungen im Vergleich und eine kürzere Aufenthaltsdauer, also eine kürzere Sedationsdauer während dem Aufenthalt auf dem Notfall. Das heißt, je nachdem ist das durchaus etwas, was hilfreich ist. An dieser Stelle immer noch den Reminder, Lachgas 50 ist vor allem anxiolytisch und weniger analgetisch, anders als Lachgas 70. Zusammengefasst ist das sicher eine gute Option für kurze, nicht sehr schmerzhafte Prozeduren, aber eher in der Kombination mit Lachgas. Und wenn man Lachgas 50, wenn man Lachgas 70 hat, kann man es sich vermutlich sparen. Und dann hört das ja nie auf, man kann alles zusammenmischen. Man kann Lachgas und Fenta und Dex nehmen. Und zunehmend habe ich dann den Eindruck, dass die Leute einfach irgendwas noch mit dazu tun können, weil das könnte man ja auch noch ausprobieren. In dieser Studie für Meningotomien mit Tubusinsertion bei Otitis mit Erguss und lustigerweise überhaupt keine Nebenwirkungen, eine ganz hervorragende Kombination. Insofern, ja, auch das ist publizierbar und auch das ist etwas, was wir berücksichtigen können. Fragen nicht an dieser Stelle, sondern gerne am Schluss. Und darum fasse ich nur ganz kurz zusammen. Eine gute Analgosedation ist kein Zaubertrank. Wir müssen unsere Medikamente wirklich gut kennen, uns gut überlegen, was für welche Prozedur und warum. Lachgas mit einem Sedativum kann je nachdem helfen, die Maske zu tolerieren. Lachgas mit Fentanyl kann man vor allem für mäßig schmerzhafte kurze Prozeduren verwenden. Vielen Dank.
Thank you very much, Julia, for this wonderful review. Again, as we said yesterday, at the PROSA conference, we'll be having another opportunity to go through details of each of these and speak with the experts. But this was a great review on some of the work you did. Thank you for mentioning our paper as well, Julia. And you are right that there's little evidence, right? I mean, so many of these are case series, some of comparisons in the dental literature particularly, but clearly we need to be able to get even more. You're getting some thanks and congratulations in the chat box, Julia. Thank you. So before we move on to the questions part, we have Koen van Hansebroek. So Koen is a friend, and yesterday Pete said I was his friend. Now Koen is my friend too. And I got to meet Koen at some of the PROSA conferences on the, or peace tour we call them, on the American side. The first time I was in San Francisco, and I will give you an insight that the first time I met Pete was in Cancun, Mexico, at another conference of these as well. But Koen has since been a wonderful friend, and to me, he's really someone who is inspiring for many ways. So briefly, when I asked him, how should I introduce you, Koen said that, well, I'm a nurse coordinator of pediatric pain and sedation management at University Hospital of Leuven in Belgium, and he's a faculty member of PROSA. And Koen forgot to tell me to put in the presentation that he was also Belgium's past president of the Belgian Pain Association. So how could you forget to tell me that, Koen? And Koen has done some wonderful things that we're also trying to replicate in Geneva. And this is what he's going to talk to us today about. So Koen is speaking to us about a nurse-led dexmedetomidine program. That has been an inspiration throughout, I think, even across continents. And as you prepare to share your screen, Koen, allow me to thank you for being here tonight.
Yes. Here we go. Hello, everybody. Thank you, Cyril, for a nice introduction. And thank you for the organization to invite me to tell and share about our experiences with a nurse-led intranasal dexmedetomidine protocol. There are no conflict of interest. Small overview of what I'm going to talk about. In the title of my presentation, there are three very important words, and I'm going to talk about that. First, about the nurse-led sedation team. I will give some extra information about dexmedetomidine, a medication, and then I'll share our protocol, which I know several of you guys are waiting for it and to hear about it. And then we'll have a little conclusion about that. This is the hospital where I work for, and on the right-hand side is the pediatric wards. We are quite a big hospital, so there's quite a new building with a whole lot of children who needs help and support during procedures. And this is an inside look of our new pediatric department. It's about 3 or 4 years old, yeah, 3 or 4 years old. So quite new and very nice to work in. As I said, nurse-driven. Our sedation team is called PROSA team. PROSA really meaning procedural and sedation and analgesia. Is the team taking care of children who need procedure and, if necessary, sedation or extra anesthesia. And a nurse-driven is kind of quite simple. There's no physician at the immediate site. We are all alone doing the procedure. We have backup, but on the site and during sedation, as a nurse, we are all alone. with the patient, of course, and the parent, but there's no physician at the admitted site. So it's nurse-driven. How does our work environment look like? We do procedures outside the OR, also outside intensive care. It's somewhere else. We work on several locations within our hospital, mostly radiology, the nuclear ward, and also, of course, our outpatient wards, consultation, hospitalization wards on our children's hospital. And we work very closely with the Department of Anesthesia. Like I said, the nurse-driven in Belgium is quite simple. We're very restricted by law. We're absolutely not allowed to prescribe any medication. So if we need some for sedation, we have to ask to the physician who is asking us to do the sedation. Also, the use of medication, we are only allowed to work with slow-working medication. So unfortunately, no propofol and no ketamine. So those options are gone. We have to work with less predictive medication, but in our hospital, we allowed to use dexmedetomidine intranasally after we have a consultation with anesthesia. So nurse-driven is also independent, and like I said before, there's no presence of physician during the sedation. How does our management of PROSA team looks like? This is our PROSA team. There's a picture from almost a year and a half ago. There are two main streams. On the one side, you have administration and logistics with a medical manager and a nursing manager. And on the other side, the operational side, quite important. And we have two dedicated staff members of anesthesia who are our backup and really standing by if necessary. And because it's all really important to have that safety measures for every sedation we do. How does it work? In short, the pediatricians in our hospital can ask us by phone or digital way to do sedation. There are several options for the children they have for their own patients. The nurses on the wards can always phone us and ask us for advice, or if they have trouble, or if they have questions about procedures, they want to help, like a child with neither fear. We have quite a large group of child psychologists. There's also there's nearby psychiatric wards for children, where also, for example, neither fear problems are there. So in any cases they want to discuss, they jump by the phone or email us for help about it. And also very important, the parents are able to contact us through email or even by phone if they have specific questions or worries about procedures that were going to come. So everything is then put in kind of a digital booking system, kind of an agenda that we get every day. And in case of complex cases, we need, and we have that opinion of anesthesia, our two dedicated medical staff. And it's also very important for every request for intranasal dex, a sedation that must be approved by anesthesia. I can tell you about our history, our evolution of operations. It all started in 2014 with a nitrous program. We evolved with our hospital. It started with the pediatric wards, and by 2016 we started a collaboration with anesthesia, and in 2017, very important date, introduction of intranasal dex. After that, we did a lot of other things, but today we're going to talk about intranasal dex. Dexmedetomidine, it calls also Dexdor, and the States is Precedex. You will hear Dexmed and Dex, but it's always one and the same medication. First and foremost, dexmedetomidine is a sedative, does not do anything about analgesia, and to be more specific, is an elective alpha-2 agonist. What does it do? What is the effect on the child? It mimics natural sleep. It's kind of a, I explain that to the parents, a kind of chemical nap time. When it gets a medication, the child will fall asleep. And while sleeping, the heart rate will lower down and the blood pressure too, which is a normal reaction if I go to sleep. If we go to sleep, the heart rate and the BP is going down too. When used intranasally, you have to keep in mind that there's a time to onset between 30 minutes and 45 minutes. And the half-life time is about 2 hours. So it's really effective for those 2 hours. And very important also is to be careful with patients known with cardiac arrhythmias. If you use dexmedetomidine with a patient known with cardiac arrhythmias, you might get in trouble, more arrhythmias, and so on. So in that case, in our hospital, when the patient is screened by anesthesia and is known like cardiac arrhythmias or congenital heart defect, the group of anesthesia will take over the sedation, and we won't do it as sedation team. Also, when a patient is known with apnea, if you give dexmedetomidine, your patient will get that apnea during the sedation. So we have to be very careful for that. Intranasal, that's actually a way that works really well. And the nose is not only used for smelling, but also for putting in medication. And their advantages are quite big. It's painless. Well, Dex is painless. Like the previous speaker talked about midazolam, this is very painful because it stings, but Dex is not. You don't need a needle to give the medication. It's easy to administer. There's no IV line necessary, and there's no first pass metabolism. And you have a little device on the right-hand side. This is kind of called the MID, the mucosal atomization device, in which the medication is put in kind of a cloud, so it's easily taken on with the nasal mucosa. So like I said, 2017 was a key moment for our team. Before that, we used chlorohydrate. And I know somebody who is getting goosebumps with the word chlorohydrate, but we used by then intrarectally, which is not reliable. We had a lot of paradoxical effects. Once the patient wakes up during sedation, for example, during transport, it was very difficult to get them back into sleep. It had a longer effect, and potential also neurological and respiratory problems were in the area. And our protocol was, as you can see, quite heavy with extra medication and so on. So that was the past. That is the past. And 2017, we started with Dex. Intranasal administration doesn't sting, non-painful. Almost all patients fall asleep. And if they wake up during transport, they quite easily go back into sedation mode with comfort. I already talked about the half-life. Has no effect on the respiratory rate. And our protocol is quite, in numbers, quite more easy to use and more effective. But it's very important that we are only allowed to use it under supervision of anesthesia, and our patients in our hospital with international Dex must be NPO, so they're not allowed to eat 6 hours before procedure, and they're not allowed to drink about 2 hours before. So our first international Dexmed is about 6 years ago. We did it on the nuclear ward, which is most effective because it's a non-painful procedure. So it's purely sedation you can use. And the very first patient we used was our nurses went inside the room with the parents. And I mean, at least half of the staff of anesthesia was standing outside the room waiting for anything to happen, but nothing did happen. And since then, we're doing it by ourselves. In March, the year after that, we started our first CT scan. And the year after that, we went for a first MRI with intranasal Dex. When are we using Dex? So mostly nuclear procedures, MSA, bone scans, PET-CTs. At radiology for CT scans and MRI, with or without contrast. We also do bone density scans And we recently also more and more using it for extreme needle fear or children with autism to help them with their fear. The protocol, the protocol is kind of a special thing. Protocol is almost like a potion, and a very experienced person really needs to use them. And there are a lot of ingredients fitting in. You have need a lot of parts of it. And first of all, the patient, a good patient matching procedures, a pre-sedation check, the medication you use, the right medication, the right environment, the use of medevac mattress. We're going to talk about that later. The aspect of safety, the work path you have to follow, the time management you have to keep, and of course, the most important ingredient is a nurse using everything, and always have that confidence to use it. Here are an example of the doses we give in our hospital. We make a difference for children younger than 6 months and children older. And as you can see, also depending of the type of procedure is also dose depending. And we already talked about the rescue dose. So that means that if you give medication, a DEX, and the patient is still quite awake after 20-25 minutes, we add 1 mic a kilogram into the DEX to make sure they sleep for their procedure. What rules do we have in our hospital? It's only carried out by the PROSA nurse. Our patient must be NPO, so no drinking. In the time of the cooler head rate, there was they could eat just before. We have a sedation work path. I'm going to show you an example in the next slide. And on the outpatient wards, we wake the patients actively 2 hours after starting sedation, and they're then ready for discharge and go home at the alterity score for 9 of higher. This is an example of our intranasal dexmed sedation workflow. First of all, our starting the effective procedure is T equals 0, and we have to always be careful that at least 24 hours or even more before that, the medical file of that child is checked by anesthesia. This is a really important thing of our protocol. Once it's checked, we can go to the next step, which is about an hour before the procedure, going for the pre-sedation. This is our first contact for the patients. Well, about 90% of the times is the first time contact with the patient and the parents. We have a checklist rundown. PO, operate anyways, are they sick, having fevers, allergies? And then we contact anesthesia for a green line to start the sedation on itself. So that's a double check. Then about 40 minutes before the procedure, we start our sedation. The preparation in an adequate environment and a calm, dark, trustfully comfy for the child, sometimes in the arms of the mother or the father. It helps. We give the medication. We start the monitoring. Once sedated, we use a medevac mattress. I have a picture of that later on, so that we can help the child for a sedation. Once sedated, really sedated and ready for the procedure, the monitoring keeps going on. We register the parameters, and if necessary, we provide additional explanation to the parent, who is always there with their child. So we keep them always together. And about an hour after the procedure, well, sometimes it's earlier, sometimes it's longer. Some nuclear procedures are more than an hour. Then we transfer back the child to the unit, always keeping in mind for the monitoring. There's a handover to the colleague. We call anesthesia and give a debrief about how it went. And then we have to fill our information and files. As you can see, it's labor intensive, it's one-on-one. And if I have a patient for a nuclear ward, I will be busy with that one child and parent for almost 2 hours. So you have to keep that in mind. And time management is important, as you can see. This is an overview of our hospital. And also to show you how the DEX locations are. This is the main entrance. Here is the pediatric wards and consultations. So on those locations, we give also DEX for consultation. But sometimes we have to go for the CT scan, which means we have to take a walk for at least 10 to 15 minutes to get to the CT scans. MRI, same story. A lot of steps to take, nuclear ward, and also the bone density scan is quite a long way from our ward. So this is very important for our time management to get on time and to start on time to be there for the procedure. And what about safety and efficacy? Well, we kind of an audit of what we did, of what we're doing, of how we're working about the use of international DEX. It's also being published. First of all, it's our PROSA database was between November 2014 and June 2029. And as we started our DEX in 2017, by then we already had 772 patients get an intranasal DEX. And as you can see, almost 75% of those children get an intranasal DEX were younger than 3 years, the youngest about 4 weeks. And always be careful and make the right choice with type of patients. We worked with SAA class 1 and 2, almost all of them. These are the procedures done for those 700 patients. And as you can see, the majority is nuclear imaging and CT scan. But also for lumbar puncture and puncture for the portal cath is also an option we started to use. What about efficacy? Well, the number of sedations to except for with one dose, just only the one dose in the nose was 91%, and an additional 5% worked with an additional rescue dose. We have a failed sedation rate of 1.7%, and so only 12 over the 772, and also all in different kind of procedures. What about adverse events? Always no major adverse events, lower heart rate, and mild desaturation is meaning around saturation of 1991, not going lower on several procedures, but only a lower number, like 13 on 7, so 1.7% also. In conclusion, we concluded that our nursing-driven PROSA setting was effective and safe for the use of intranasal DEX for non-invasive procedural sedation in a pretty low-risk patient, pediatric patients. So I promised some pictures from the workflow examples. Here are examples of nuclear ward. These are 2 kids sleeping for the DMSA. That's a scan for the kidney. They are asleep. They are in a blue mattress and they are monitored. And this is also a child for a PET CT, also nuclear ward. There you can see the blue mattress around and the monitoring while the kid is sleeping. And we are always by their sides together with the patient, parents. This is an example of twins needing a CT scan. We did a pre-sedation check at the outpatient wards. We started our sedation at the ward. As you can see, the twins are laying down comfortably when the blue mattress around, having their own monitoring. Here they're asleep. We arrived at radiology ward after our walk of 10 to 15 minutes. Once arrived, we prepare them with the mattress. And then we go inside the CT and help them for their scan. And as last example is a 4-year-old little guy with a big tumor on his kidneys. who got intranasal Dex while he was lying in the arms of the mother. Once he fell asleep, we put him on a mattress and we closed everything. Monitoring is on it. Is being prepared on a MRI table, and also his ear protection is on because it makes a lot of noise. And once we're told that the MRI is ready, we can walk him in. So in conclusion, we can say that a nurse-driven PROSA team can use dexmedetomidine effectively and safely with a good sedation protocol. Important is to know that sedation protocol is more than medication and doses alone, so we need more than that to give. And keep safety and backup nearby. In our setting is a good and open communication with the Department of Anesthesia. And here I have a few more publications about our work about intranasal Dex. Thank you for listening. And if you have any questions, I'll be happy to answer them. Thank
you so much, dear Koen. Your work is really an inspiration. You know, for example, in Geneva, we just got some private funding to have a PROSA nurse, 50% for 2 years. We are so happy with that. Maybe what I can do, Pete, is I'll ask quickly Koen a question, and then I'll give the rest of the floor to you for the remainder of the questions. Koen, how did you create the buy-in around having this wonderful team of nurses? Because they often tell you, oh, well, those are, you know, it doesn't pay. It's who's going to pay for the procedure? The care of the nurse is usually not very well reimbursed. What could you advise us if we're trying to make a point to administration to get more people for PROSA?
Well, first of all, you have to start small. Like we did, like I said, it's almost 10 years ago, we started it with a nitrous program, and we were helping children not every day of the week. What we do now, at the beginning was not. So it was first a program starting around a project that you're sure of, and then you can build on. And there's also a lot of show, don't tell. So if they see it's working, then they're getting interested, and then you can grow step by step. And also it's very important is the safety, because if you go do sedations and you have one time a very big problem, the whole program will go down. So you have to be very careful with that.
Thank you for that great answer. We have to pull the administrators and the hierarchy inside the room and show them how it's working.
And show them. Yeah.
Perfect. I'll do that.
Yeah.
Pete, the floor is yours.
Thank you, Cyril. Thank you, Koen. Koen, I give you a very short break because there are a lot of questions about what you have explained. Practical questions, of course. It is no surprise, I think, because it's very innovative what you're telling. But I just give you a small break, have a drink, whatever, and maybe I can first move to the other speakers. And Lucy, there's a great question in the chat. Maybe you've seen it. There's a question by Laura Meyer who asks, I'm interested in understanding how cultural and psychosocial differences, but also resource-oriented possibilities are considered in the protocols and recommendations for treatment. Wow, that's probably
easy.
That's probably a separate lecture or whatever, but this is clearly someone who is asking for support in implementation from these guidelines, these I-support guidelines, into the real practice, the daily reality. I think it's a great question. Can you please comment? Can you, and Laura, feel free, if you want to start a dialogue with Lucy directly, to switch on your microphone. I think that's possible, and ask the question further if needed. So please, Lucy, could you?
Okay, thank you. Yeah, so that's a really complex question, and I think there's so many considerations within cultures across, and we found that, you know, Pete's part of I-support, we found that when we were working across different cultures, across different countries, but also there's so many cultures within one hospital, practices, departments practice in different ways, there's different accepted practice. So culture and organizational expertise are really important, but there's also cultural differences in how different cultures see children's rights and agencies. So there'll be different beliefs around how communication occurs with parents and extended family members. So it's really important to recognize that. And I think that's where we need to just kind of remove assumptions that we have when that child comes into our care and just look at what is working here. What are the child's previous experiences? So what came before? What's this child bringing with them? There might also be parents who come with their own procedural experiences. There'll be parents that come with their own kind of cultural expectations. So it's very, very complex. And I think it's just, if we can kind of stop and just think about what is going on here for this child within this context, within this family, within this hospital in which we're delivering care, or within this department, then I think that's really useful. I think when it comes to looking at how we implement certainly the I-support standards, we worked really hard that they are principle-based and can apply to kind of any setting and any child, and that need to be considered to what that looks like for that child having that procedure within that department. So actually, what can we do? What small marginal gains can we make to improve that procedural experience for that child? So looking at, has that child had information and preparation? Has that child had choices? Does the parent know what's happening? So looking, actually examining for that department what that journey for those children and young people look like as they're coming through. It's not easy, but yeah, all those things make a huge difference. I'm not sure if that answers your question.
Yeah, I think it certainly does. You know, when we in our courses discuss the I-support standards, and we very often get actually the most simple cultural challenge, that is the parents who actually say to the professional, just move on, just go, do it, because we are in a hurry, or this child just needs to be restrained because that's how he's used to do it. Would you say that actually these principles, these new supports, these I-support standards, actually asks from us professionals to take the position of the child's rights, irrespective of what the parents are actually putting in?
We are there as advocates, aren't we? We're there as advocates for those children's best interests. And I think sometimes parents will push the boundaries that professionals feel comfortable working in. But that's because those parents don't necessarily know that there's a different way to do it. So they might have had 3 previous experiences where the professionals have said it's better to get it done, and where the child has been distressed and the procedure has been completed. But unless we advocate for the child and help the parents see that there could be a different way of doing this, we can offer different ways of doing this. Really, it's not ideal for your child to be this distressed, because we know that this might impact on them in the future. Unless we feel able to challenge that, then those parents are advocating for their child based on what they know, and that's limited. How could they know more than what they've experienced before? So yeah, absolutely, we should feel able to say, look, I think we can do better for your child. Let's think about what that might look like.
So that's I think that's an excellent way of putting it. I just want to, as a kind of final question for now, there's so many practical situations in medicine that actually holding down the child is very quickly done. It's very rapidly there. Just to give you an example, a child that has to enter anesthesia, the induction mask, it very often is a short fight. Or you have this child coming in with shortness of breath. It needs nebulization with salbutamol, and it doesn't tolerate the mask. But then the drug is needed to treat the child. So if we are in that situation, this kind of dilemmas, what would you advise based on these I-support standards? What's the right way to perform, and not only at the moment itself, but also afterwards?
And I think that's really difficult, isn't it? And each situation is unhelpfully different, so it makes it very difficult to make a blanket statement around yes, that's the right thing to do, or that's not the right thing to do. I think even just if a child has needed urgent treatment and has been held, then let's at least document that. Let's at least acknowledge that. Let's at least think about acknowledging with the parent and the child that that happened and that happened for a reason. And we felt that it was really important to have that medicine and have them an opportunity to make sense of what happened, and for us to be able to provide a justification that we feel confident that it was the right thing to do at that time. If it wasn't the right thing to do at that time, then let's be honest enough about it and think, okay, so that probably shouldn't have happened in that way. How can we do that differently, or how can we support the child and the young person to understand what did happen?
So that also means that Benedict has this publication on empathic blindness. There's also a lot of reporting blindness. We just don't write it down in our patient files. It just happens. And then we have this great quote by one of our psychologists who wrote, so in the patient file that a chest tube was removed successfully according to the surgeon, but she heard from the patient that it was one big fight. And in the medical file, it was just written, chest tube was taken out successfully, point. And that was all. So actually there we should write down, this was a fight. We had to use restraint. That's actually what you're asking us to change in the practice as well. Yeah.
Because I think that raises it above something that's acceptable, that's taken for granted. It raises it as something that's worth acknowledgement, that we have had a child that is very distressed and needed restraint. Let's be brave enough to acknowledge what happened.
Yeah, wonderful. Okay, thank you. If there are comments for Lucy, please add them in the chat. Cyril is checking what's getting in the chat. Cyril, do you have anything to add for now, or?
So thank you for asking me, Pete. But part of me, trying to think about how I'm going to get one day to Koen's program, or to Anna Tadio's, or to Lucy's way of working is, I mean, one day would it be truly a part of children's right, all of these different things, so that at that point there will only be one way of doing this? For example, in American hospitals, you have the Joint Commission that has to make sure that this, that, and that is being done correctly. We don't have, for example, in Switzerland, as much supervision of our clinical work. And, is it one day that the policing of that will be what will lead to change and to more money being input to have 10 nurses or X number of nurses or doctors that work around this? Lucy, I'd love your thoughts.
So I hope to goodness in 15, 20 years time that my work has no relevance at all, because practice looks different. I would hope that my references are so dated that no one could use them, because practice will have looked different. And I think that it's just those marginal gains in trying to make a difference. I would feel very sad if children were still being restrained for non-urgent procedures in 15, 20 years time. And we have seen things that we accepted in practice, like the neonates undergoing procedures without any analgesia. Practice can change. We do get there. It takes a little bit longer than we would hope, but I hope to goodness that my work has no relevance in 15 years' time.
Yeah. So that's a task for us, Cyril, for our organization. Yesterday you mentioned that if we want to measure the quality of procedural meetings and procedural sedation, we should evaluate 1 or 2 weeks after the meeting to be sure that the impact we had is not just determined by the observation at the moment itself. So that's something we then need to add to quality. I think holding down, restraint, whatever you call it, should be monitored for each procedure, and each procedure where you use restraint should be a red flag raised. Here is a point for improvement, just like a central catheter infection or any other thing, any other adverse moment. So I think I saw that Benedict is rather pessimistic that you will still have to move a long time on, but I think we are moving. This thing are changing. Okay, thank you, Lucy. I have a question for Julia. You, at the end of your presentation, you had this publication of the combination of Dexmet, fentanyl, nitrous oxide. This was like the kind of a magic mixture that we very often see that in the sedation world, that people start mixing things like the Asterix and Obelix magician that is mixing everything that could be put in, and then let's do something in the child. I had the impression that you were like a little bit critical about this combination. Can you comment?
Actually, it's not the specific combination. I'm critical of mixing anything just to mix it.
Yes.
And I got the impression that if you really know what you're doing, you might choose other options. But this is the point of view of someone who's able to choose between many options. And I think most of these studies are done in outpatient clinics or places where anesthesia is not around, intensive care is not around, no one is there to take care about advanced airway management, so they're not able to do that. Well, I think there is a considerable risk in just adding other medication that all of them by themselves might not be that risky, but no one knows what happens if you mix them. So
yeah. So actually, what I think that's a very important point, that we should be aware of the fact that sedation bears the risk that it becomes the magic tool for anything, and that we should know what we are doing despite the circumstances we are working in, and it should not be an excuse for not going to anesthesia if that would be or deep sedation if that would be the better option. Cyril, you want to comment?
Yes, so that study that Julia referred to by Trombetta, the Italian folks, with one of the last authors being Egidio Barbi from Trieste, was a very interesting study because, you know, as you say, Julia, they had to have the patient sleep so they could put the tympanic membrane tubes through. But, you know, they figured there must be an element of pain. And so they gave fentanyl on top of everything else. But if you look at the adult literature, for example, James Miner wrote 2 studies looking at adding or not adding for big procedures such as fracture reduction an analgesic to a propofol sedation, which is purely hypnotic sedative and not analgesic. And what he shows in his studies is that patient recall, patient satisfaction with the procedure, procedurist satisfaction, etc., and the levels of catecholamines that were measured in the bloodstream of those patients did not change whether you added an analgesic or not. So I love what you're saying, Julia, is do not mix just for mixing. Think about it with the potentially big, completely earth-shattering news that when you are in a deep sedation like propofol, well, in the adult literature at least, with the perhaps not necessarily the most, you know, complete studies, maybe they should have called the patients 1 week after and asked them as well, how are you feeling? Well, perhaps sometimes if you're deeply sedated, then you don't need an analgesic. It's something that needs to be looked at, studied. As you said, Julia, not enough literature. We have to keep going.
Yeah, but here as well, Cyril, I think we should be careful. We should assess quality very carefully, because we also know that if you, in painful procedures, if you don't use analgesia, you will need much more propofol. And so the risks become higher as well. So we should be very careful to make it black-white stories. It's always, and a final warning just, and that's something I just want to bring in. This study has had 16 cases included, 16 patients. And there is a great editorial that for me is like a guiding principle, published in 2016 by Joseph Cravero and Charlie Coté, 2 of the godfathers in procedural sedation. And the title of that editorial is Raising the Bar for Sedation Studies. And they actually argue that studies with a lower number of patients, lower than 1,000 patients, doesn't tell you anything about safety or effectiveness. So we should be very careful in using low numbered, look to Kuhn's study, 5,000 cases, that's valuable information. So let's be careful with very low numbers of studies. They can inform us, but at least we should be careful to just use them as protocols or to copy paste them. Yeah, great. Koen, are you ready, Koen, for a few questions? And if any of you want to bring something in, please add it. Dexmedetomidine. There are a lot of questions about dexmedetomidine. And let's first start with the concept of nurse-led sedation. The fact that a nurse is running this within the restrictions of the legal settings you have in Belgium. What would be needed to make nurse-led sedations everywhere available? Can you comment on that? Because it's apparently a very good strategy to implement this wonderful sedation strategy in a busy program. What would be needed in Europe if we want to make that possible everywhere? Because I think even in Switzerland or France, maybe there are limitations for this kind of sedation protocols. Could you comment on that, Koen?
Well, that's a very good question, and I'm afraid I don't have really the straight answer, but I think it's important to show, as what we are doing, that it's possible that as a nurse we can do sedations if you know where the boundaries are, and if you work closely or like we do, like with anesthesia, to stay in a safe area, so that you know this is possible and this is not, and to stay in there so that you don't become a kind of a cowboy and trying this or that because it's worked last time. Yeah.
So it's all about creating a context within the regulations you have. Because there was someone from Greece who was actually commenting on Julia's story that in Greece, apparently nitrous oxide is not allowed to be used outside the operation room. So apparently there are rules there that still need to be challenged. Did you have to challenge rules when you were implementing this, Koen, or how was that?
Well, I had to challenge rules indeed, because the use of DEX by nurses is legally not allowed. We have a kind of information with our anesthesia, and by publications we could show that it was possible and that we can kind of help in the work of anesthesia, that we're taking about, we're doing more than 1,000 sedations a year. So that's a whole package that anesthesia doesn't have to do, and they can focus on more complex cases. And that what we can do on basic ones.
Yeah, wonderful. Okay, there are a few other questions. First simple question was, okay, there is this risk, you shouldn't use it in children with bradycardia or with a cardiac conduction problem. So does that mean that you do an ECG in all your children prior to dexmedetomidine, or how do you assess this risk? How do you do that?
No, we don't. That's anesthesia. We kind of do a checking for general anesthesia, and we don't put everyone on EKG before the patients known with problems. Then we can avoid them, but mostly that's the reason. If they're known with it, you don't have to take EKG for all of them. No.
Yeah, okay. And you also mentioned the risk of getting an apnea in children that are known with apnea. Could you give an example of what kind of child wouldn't you, where would you go for intranasal or intravenous dexmedetomidine? Which children are that?
Yeah, one of the things I always ask my parents the first time they see is, describe me how your child is sleeping at home. If during the nap time, are they sleeping comfortably? Are they stopped breathing or not? And when they tell me, well, mine is snoring very hard and then stops for a few seconds and go again, then that's for me a kind of a red flag. Be careful, and then I can check to my anesthesiologist, so can I go through with it or not? But on the other side, if you're prepared, we've already sedated patients with a BiPAP system at home, that the mother of the parents bring the system at the hospital. We gave them intranasal DEX, and when they fall asleep, we put the system on so that they're used to it, and then we can do the procedure we want to with it.
Yeah. So we could actually use the great summary Kira Mason mentioned a few years ago in one of her conferences, that if a child has no sleeping problems at all at home, and you can actually safely use dexmedetomidine, you will not expect any sleep-related hypoventilation or apnea. Could you?
No, that's how we check it. Yeah, we don't send everyone to the to check if they have apnea or not. Yeah. The same as EKG.
Okay, so there was a completely other question, which I loved. It's a funny question. It has to do with this very long half time. It works very long. Children are sleeping for 2-3 hours after dexmed sedation. Also, Julia mentioned that in her presentation. And there is this drug atimipazole. Maybe, I don't know whether you heard about it, but apparently it's used in dogs. When dogs are sedated with dexmedetomidine, afterwards you administer atimipazole, and then they wake up within 10 minutes. It's an antidote. Have you any experience with this? Because I don't know of any study in humans.
I don't have any experiences, but I heard from Cyril that it existed. So
yeah,
we don't use it.
His dog was sedated in that way, I believe. And he's still alive, the dog, Cyril? Still,
She's alive. And it was quite
Yeah.
amazing when the veterinarian said, now I'm going to wake up your dog. And I said, you're not going to wake her up. She's going to wake up in 3 hours. And she said, no, I'm going to give her a medication. And
Yeah.
she gave her the
Yeah.
atipamezole IM, intramuscular.
Yeah.
And after 10 minutes, she was wagging her tail.
Yeah. I remember
It was
I
a
read
wild
about it. I remember I read about this drug some years ago, and I checked the publication again that is in my laptop. And indeed, it's theoretically possible to wake a patient up after Dexmed, but there are some warnings. First of all, it increases the sexual activity in rats and monkeys. Okay, I don't know what we have to do with that. But another thing is it increases pain-related responses as well. So I think and there are no human studies so far, at least I couldn't find any. So unfortunately, that's not yet a solution. So don't start experimenting, Cyril, with based on your dog. It's so. But how do you deal?
Trial going on.
Yeah. So how do you deal with this long half-life time, Koen? Because the children after the MRI scan or the CT scan, or also Julia has them on the ER, maybe after a painful procedure. What do we do with this? How long should they stay on the monitor if they sleep so long? They could block your whole system in the hospital.
Well, that's also one thing when you try to implement something, you have to see what's possible in your hospital. And we have the luxury, if I may say so, that every pediatric bed in the hospital has its own monitoring system. So everywhere we as a team, we pick a patient up from the hospitalization ward, we go to CT and back, put them back on monitoring, and they're still in there. We have a kind of agreement that after 2 hours, we really try to wake the kids up, and then mostly they are awake after 2 hours. Mostly when we open the mattress, the blue thing, we use a lot. After procedure, we open it again. That's sometimes a trigger for the kid to wake up. And once they open their eyes, it's okay. They might fall asleep again afterwards, but it's kind of a check for us.
Yeah, excellent. Great question. I think we got from the audience also for Julia. You're working in Switzerland. I was told that in Switzerland, typical for Switzerland is that there are mountains in Switzerland. And somebody asked the question, what's happening with nitrous oxide on a higher altitude? There's apparently research showing that on a higher altitude, that the laughing gas, the nitrous oxide, is not working properly. Can you comment on that?
Actually, I cannot. I'm right next to Davos, but I never heard that it's not possible to use nitrous oxide in Davos.
Yeah.
I have to check with my colleagues there because I'm sure they have it as well. But
on what altitude are you working in?
Sorry?
How high is your hospital and what's the altitude?
It's just next to the mountains. It's not up the mountains.
It's not up the mountain. And Cyril, do you know?
No, it's
so I don't know any more than Julia in terms of mountains, but you did point to that paper and that link in PubMed that was mentioning some things, Pete.
Yeah, indeed. There's old literature indeed suggesting that in higher altitude, because of the lower pressure, that it's just working substantially less. So yeah. Okay, that was a great question. Was someone who's working who's working in now and then in Switzerland who commented on that. Okay, great. Other questions, Cyril, that you want to bring in? I have one for Koen. Yep. While you are looking, Koen, someone asks, we have tried to sedate 2 children with some mental problems, with developmental problems. We tried to sedate them with dexmedetomidine and they just did not fall asleep. It was not working. Well, is that something you recognize in certain children? What could be the cause? What to do with this?
Yeah, we recognize that sometimes the fear of something happening will keep them awake. Sometimes they're so fearful, bad experiences from before, like Lucy said, and that's sometimes the trigger just to wake to fight for that medication. And some kids are really good at it. So what we do sometimes, even that we hear that in preparation, so that we have a part of the kids we prepare beforehand. When the parents contact us, well, we have a CT scan in 3 weeks, but we have very bad experiences. What we can do, and in the talks with the patients, sometimes we give some medications, kind of anti-anxiety medications before, and then we give a Dexmed so that they're more receptive to it.
I will add, I will build on the answer of Sharon Vandenberg from the chat, who says that what they often do is that you need to remove all the stimuli, light, sound, etc., and wait and leave the children alone until the right time, about 40 minutes. And that's often what we do, as Koen had mentioned initially, when we first started using that drug in the emergency department, we were all standing at the door waiting for something to happen, the effect, not the side effect, the effect. But indeed, what we do now is that we try to use our physiology, our good sense, and we also do not put the child on the monitor, but we do clinical monitoring until we start seeing the first signs of drowsiness. And then we
So it's all about the environment, creating a sleeping environment, actually. And that's quite a challenge in a medical setting, I think. It's it's happy that you, it's funny that you say this, Cyril. I was invited a few years ago in a hospital somewhere in Europe, I'm not going to mention the country, but to advise about dexmedetomidine in sedation. It was really a debate in that hospital because the anesthesiologist did not trust that this medication was safe. So they suggested to me to witness an experiment they were going to do. They would sedate the child with dexmedetomidine in the full white light of an operation theater. And indeed, it did not fall asleep. So that was for them the proof that it's not working. So yeah, fortunately, many have learned how it works after since then. Okay. What do we have left here? Oh yeah, bringing maybe the stories together here. We heard a lot about intranasal drugs. Julia mentioned them as a kind of an add-on to nitrous oxide. You mentioned them for the MRI scan. But I see a lot of children who just do not like intranasal drugs. And okay, we sedate them to avoid restraint or holding down, but maybe we start with holding down for bringing the medication in the nose. So we actually remove the problem. How do you deal with this resistance of children? What are the solutions to bring in a nasal drug in a friendly way? Could you, Julia? And then we'll listen to Lucy whether that's in line with the I-Support guidelines. So
our experiences is that when we hear they had bad experiences about that, then we go another way. I mean, like I said, 90% of the kids we see on the day itself, on the moment itself, but the parents are more and more open in telling about bad experiences. And when we hear that, one of the things is preparation at home. We give an MRI device and let them play at home. They can see it and they can feel it in a safe environment with water. So that's one of the things that we do for it.
Yeah, but that's at home. That's actually in line with what Cyril in his great paper in JAMA published as well. But Julia, in the ER, what would be the option there when you can't send them home first to practice and then come back with a fracture arm 1 week later? So what do you do there?
Well, actually getting older and older, I really start to do that because there's not so many really emergency procedures that I need to do right now and then. So if I have the option to take the pressure out of the system, I will more and more just do that and say, if this is not a good situation, I have to decide if I really need to do the reduction right now. Because there's not many situations that I would really need to do that. But this is, of course, it's not always possible because of the constraint of the hospital system. I think so. Yeah, it's really the question of, is this the right moment? Is this the right patient? And does it make sense to force someone to take something that will make him more relaxed?
Yeah. So that's actually what you say is you're changing the routine. You're changing the traditional protocols based on what you consider is the best option for the child. Yeah. That's wonderful. That's exactly the way we have to. That's promising, Lucy, don't you think so? If you hear this, that it's not a protocol, but suddenly people take the child's interest into perspective.
Yeah, absolutely, and that's as it should be, because it's, you know, if you're going against a child's will to shove something up their nose, they're going to remember that. They're going to be cautious next time. They're not
Mhm.
going to want to engage next time. They're not going to trust someone who comes towards them and say it's fine. It'll be fine. They've got no reason to believe that it will be fine because it wasn't fine last time. Yeah, so I think that's just examples. Julia answers that beautifully. It's just an example of really good practice. You know, and you can always provide the children with some degree of choice, even in a relatively short period of time.
Yeah. So we are moving away from sedation as a tool to restrain the child as well, because it's really a part of a comfort strategy. That's great. Cyril, please.
I'd love to add on what you've said. So we, in our program with children with autism, and it's all an appointment, we meet the child, quote unquote, a week prior through a phone call to all the families, making sure that they have received a list of instructions, including how to speak to the child about their visit, the prescription for the amla patches, the spray in the nose of habituation. I used to say desensibilization, and then somebody told me, a French person, Benedict, maybe you know them, I'll tell you about them one day. He's like, why do you say desensibilization? It's not about, they're not sensibilized, they have to be habituated to what you're doing. It's not something that they're supposed to be necessarily already scared of. So we habituate them at home with this spray. But we have also noticed that once they come, we really let them do a lot of the work, and we have learned that sometimes when you give little aliquots one after another, instead of just giving the entire 0.5 ml in one nostril in one go, well, clinically, we haven't seen, and maybe this is anecdotal, we don't have 2,000 patients yet, but clinically, we haven't seen any more failures. We don't have many failures in our program, thankfully. But clinically, given little aliquots, which to me are probably less noxious to the nostrils, in the parents' arms, perhaps the parents are giving. We also see our teenagers with autism given the aliquots themselves. Then this seems to be increasing acceptability, and perhaps preparing also for emergency moments where now they know what this is like.
So actually what you're saying, Cyril, is that you make children and parents competent in the strategy that you want to apply. They become competent collaborators with you. And that's fully in line with, I think, the third recommendation within the standards. But it's all about helping children to become competent, to know what they have to do, and to train them to make. That's different indeed. That has nothing to do with desensitization, but it's building skills in their mind and knowing how to collaborate with you. Is that correct, Lucy?
I was just going to say it's procedures being done with rather than done on and to, isn't it? And that makes a huge amount of difference, particularly for young people, autistic young people who would have high sensory needs. Cyril, it's amazing practice hearing you talk about that, because their sensory needs within that environment, and having something that's likely to have a smell and a texture to it would be quite anxiety provoking, but giving the control to them to be able to control that would make the real difference. That's amazing practice.
Okay, these are very wise words. I think it's my impression that we have managed to deal with all questions that I have seen in the chat, and I don't see any new questions coming anymore. So I think, Cyril, I suggest we move to just a final short set of slides that we are going to share, just to ask the people for just stay another few minutes, and then we'll leave you with your family. So whatever you intend to do this evening, I'm going to share my screen. Where is it? This one is the one I want to wait, I have to do this again, excuse me. Let's have a look. Yes, it's all okay. Where is it? There is it. Okay, can you see my screen right now? Is it visible? What do you see? Like this. Can you see the presentation? Yeah? Okay, so thank you all. Thank you for the speakers, today's speakers, yesterday's speakers, to join us. Thank you, audience, to be with us and to learn, even on a Friday evening. We know what we ask from you, but this seemed to be the best moment for many people, maybe living in different time zones. So thank you so much for being with us. Please scan this QR code. It will direct you immediately to an evaluation website where you can evaluate the speakers of yesterday and today. We will also send all of you an email with this link. So if you cannot scan now, you will get an email with this link. We'll send it to all the participants. So please inform us and put in any suggestion that would be helpful for us to do these webinars again, or to make them even better, whatever. And of course, let's stay connected and let's meet again. And there are ample opportunities to meet again. The first one is, and I'll give the floor shortly to Benedict. Benedict, you're still there? Benedict? Can you?
Oui, je suis toujours là. Merci beaucoup.
Can you comment on this? Can you connect on this slide? Comment on this slide?
Oui, l'occasion de nous retrouver à nouveau autour des mêmes questions qui nous animent ce soir dans ce webinaire, une philosophie de soins autour de l'enfant. Et les journées pédiadoles reprennent ces réflexions puisque Lucie sera présente à ce congrès. Comme Keun, nous serons nombreux, un certain nombre d'entre nous seront à ce congrès. Donc, n'hésitez pas à nous rejoindre pour les journées pédiadoles. Le congrès aura lieu à l'UNESCO le 20 mars.
Yeah.
Et il y aura une traduction simultanée puisque nos collègues sont en anglais et on traduira l'ensemble des conférences.
Yeah, and as you can see, it's a 3-day conference with on the first day a plenary session, and in the other days there are workshops. And the plenary session is in a really symbolic place. That's the heart of the UNESCO, a little bit, I believe, south of the Tour Eiffel. That part of Paris, it's a beautiful place to go to. So we can really recommend you to go to that meeting. And of course, Paris, there's always an excuse to go to Paris, isn't there? Cyril, what about PACTS in the near
Cyril
future?
sera des nôtres aussi.
Okay.
Personne ne veut rater Paris cette année.
So it's a family meeting, actually. That's great.
I wanted to show you the dog that survived at Tipamezol. She's right here.
Okay.
And so we are a very young organization.
Ça, c'est pas un chien.
1 year old. And we are working on launching our website. We just got funding for it, which is wonderful, which the goal is to serve as an educational hub, similar to how PROSA has done it. I'm sorry. And in 2025, we're hoping to have our first course and another congress in the German part of Switzerland.
Okay, wonderful. Good news, Cyril. So looking forward to that. There's a QR code on the bottom. So there you can see their website and follow any activity in Switzerland. And also Switzerland is a great place to go to. And of course, I'm very happy we can announce again the next PROSA conference, which will take place on the 12th and 13th of September in Maastricht. Again, same place, same construction of state-of-the-art lectures, interactive workshops, interprofessional collaboration, with this time a special attention for the very young child, adolescents, and also children with autism and neurodiversity. And here you see already the speakers that have confirmed to join our conference. Also the people that were today here with us. So follow our website. And as I mentioned, there will be special attention for autism. And this great speaker from the United States who have written a unique book on uniquely human, a different way of seeing autism, is our keynote speaker. And before we move to the last slide with a short promo video of the PROSA conference, which will end this session, I want to thank again the speakers of today, Lucy. I want to thank Koen. I want to thank Julia, and yesterday's speakers, Cyril, Gabrielle from Geneva, and of course, Benedict herself. So thank you again. Stay connected. And here's the final slide with some promo for PROSA. So, hope you all survived.
Thank you, Pete, for a great organization.
Thank you. Lovely way to spend an evening. Thank you very much.
Ouais,
Benedict,
merci.
your little person is very cute.
Merci beaucoup. Merci pour toute cette organisation.
Yeah, it was a pleasure to do so. And actually, it was very easy. This was really very easy to organize. The effort was all yours. We had a great support by Anna Dassen and the people who did the translation. I don't know whether you were able to follow the translation quality, but at least I was quite impressed about how well it was done, despite the fact that you're having a professional language. So I think we should examine future opportunities to do maybe for specific sessions. And I'm looking as well to Koen from Belgium and maybe from the UK as well, that as we organize it as a group, the price of translation becomes much lower, and maybe we get at additional languages, and